Dear colleagues and friends, welcome to the first module of the e-learning platform of the European Alliance for Haemophilia and Allied Disorders. The first topic in Module 1 is how to manage acute cardiovascular disorders in hemophilia. And I'm very happy to have Cedric Hermans with me. We will both give 3 short presentations about the topic, starting with the background, followed by a case report, and latest clinical trials and studies and recommendations in the last presentation. Cedric Hermans is the director of the Haemophilia Treatment Center in Brussels, chief editor of Haemophilia and well known to the community. And I hand over to Cedric now for the first presentation. Welcome, Cedric.
Dear Robert, thank you very much for these very nice words. So what I would like to do now during the next few minutes is to give you an overview about cardiovascular disease in our patients with hemophilia. So as you know, our population of patients with hemophilia is quite heterogeneous today. We have young patients, we have adult patients, but we also have older patients. And it's clear that in each of these group of patients, we have specific challenges. Well, regarding the young patient, the pediatric age, diagnosis, initiation of replacement therapy, inhibitor represent important challenges. And then these patients will move to the adult age with other challenges, continuation of prophylaxis, transition, social integration. And considering now the older patient with hemophilia, the senior group, well, this patient is now facing several health problems such as cancer, internal disease, but also cardiovascular disease. And it's clear that more and more we have to manage cardiovascular diseases in our patients with hemophilia. So this slide shows you the major comorbidities and medical problems that we encounter in aging hemophilia patients. On the left part of the slide, you can see the typical hemophilia-related comorbidities, arthropathy, hepatitis C infection, HIV infections, inhibitor development. On the right part of the slide, you see the non-hemophilia-related items, internal disease, malignancy, surgical intervention, and clearly cardiovascular disease. And we should also consider other important comorbidities or problems that our patients could be facing, including sexual problems, psychosocial problems, and we want to make sure that the quality of life of our patient is preserved or ideally improved. Regarding cardiovascular disease, well, this really basic slide shows you what hemophilia is. Hemophilia is characterized by a partial or complete deficiency of factor VIII or factor IX for hemophilia A or hemophilia B. The main consequence is, as you all know, bleeding problem that mainly take place in the musculoskeletal system. So this is depicted on the right part of the slide, leading to painful, debilitating arthropathy. And the question is, are our patients with hemophilia A or B protected against thrombosis? And this could be arterial thrombosis or venous thrombosis. And these are important questions when considering how to manage this patient when they are at risk of arterial or venous thrombosis. So what do we know about the cardiovascular disease in an aging hemophilia population in 2023? Well, what we know is that cardiovascular disease is increasingly detected in our aging hemophilia population. We also know, and I'll come back to that, that cardiovascular risk factors are as frequent in elderly patients with hemophilia compared to general population. We also know, and we'll illustrate this very soon, that there is a lower cardiovascular mortality in patients with hemophilia compared to the general population. So it's clear that if hemophilia is not treated or not intensively treated, well, these patients do have a hypocoagulability that's probably reducing the risk of cardiovascular mortality. So this slide shows you the results of a study that was performed in the Netherlands more than 10 years ago, showing the risk of cardiovascular disease in patients with hemophilia. I think this is an important study that shows you the risk of myocardial infarction, angina pectoris, non-fatal ischemic stroke, and non-fatal intracranial hemorrhage in different populations. In an overall population of patients with hemophilia, more than 400 patients, and then in a subgroup of patients with severe hemophilia, and in a subgroup of patients with non-severe hemophilia. And if we look at the results here, you can clearly see that when comparing the incidence of myocardial infarction, well, patients with severe hemophilia are protected. So the risk of getting an MI is much lower in the population with severe hemophilia compared to the age-matched male population. However, for non-severe hemophilia, you don't see that level of protection. Angina pectoris, no significant difference. And non-fatal ischemic stroke, again, you see that the risk of a non-fatal ischemic stroke is lower in patients with severe hemophilia compared to an age-matched population. We also know, and this is obvious, that our patients with hemophilia are at high risk of non-fatal intracranial bleeding, and this is obvious. And more specifically, the severe patients are certainly at risk. We have many studies that have looked over the last 20 years at cardiovascular disease in patients with hemophilia. So these are some of the lessons from the literature. Many studies performed in North America and in different countries across Europe. So as you can see, the results here are a little bit conflicting. Some studies show that there is no difference between the hemophilia population and the general population. Some studies show that there is a lower prevalence of cardiovascular disease in patients with hemophilia compared to the general population. And as the study at the bottom, performed in the US in 2014, show totally different results, showing that ischemic heart disease and myocardial infarction are more frequent in patients with hemophilia versus general population. So a lot of conflicting results. So this is quite difficult to interpret, considering the heterogeneity of these observations. We have more recent study from this large European initiative that looked at cardiovascular disease in patients with hemophilia. And these are the results looking at the prevalence of coronary heart disease in patients with hemophilia compared to general populations. And what can you see on this slide? I think this is obvious on the graph on the left part of the slide, that ischemic heart disease, coronary heart disease, is certainly less frequent in older patients with hemophilia, and certainly in the group 60 to 69 and 70 to 79. So a lower prevalence of ischemic heart disease in hemophilia population compared to general population. And if we now look at the prevalence of ischemic cerebrovascular disease, stroke, well, by contrast with ischemic heart disease, no statistically significant difference was found in that study. So clearly, the observations that you make might be different depending on the cardiovascular outcome that is analyzed in the frame of these studies. And regarding hypertension, and I think this is a very important piece of information, and I think it's again obvious on this slide, comparing the prevalence of hypertension in patient hemophilia versus the general population, and you can clearly see that the prevalence of hypertension is higher in patients with hemophilia compared to the general population. And this is something we need to take into account and that we need to address aggressively, because we know what the consequences could be of having hypertension. So in summary, what can we say? Well, clearly, when looking at cardiovascular disease, you need to take into account two entities, atheromatosis and atherothrombosis. And I think this is important when looking after our patient hemophilia. Well, clearly, atheromatosis is influenced by different cardiovascular risk factors that you all know: hypertension, diabetes, cholesterol issue, family history, smoking, sedentary lifestyle, and we know that this is not different from the non-hemophilia population, although I just emphasize that hypertension seems to be more prevalent. So clearly our patients with hemophilia are at risk of developing atheromatosis, but we also know that our patients are protected by their factor VIII, factor IX deficiency from developing acute arterial thrombotic events, so we call them atherothrombosis. And that could be explained by the increased plaque stability that we see in this patient, and also a reduced ability to generate thrombin following rupture of the plaque. So I think these are important concepts. It's also clear that this is true for untreated patients with hemophilia, but it's very likely that treatment with prophylaxis, with clotting factor concentrate or non-replacement therapy could result in a partial or complete loss of protection of this protection that these patients have against atherothrombosis. And atherothrombosis means developing a thrombosis in your heart, in your brain, or in the inferior limbs. So as you understand, our patients with hemophilia are at risk of developing atherothrombotic events, and our patients will need specific treatment. That could be antithrombotic agents, antiplatelet, anticoagulant therapies, or patients might be candidates for some sort of percutaneous coronary intervention with stent, and we have different types of stents. Bypass grafting could be an option, as well as thrombolysis. So clearly important question here, how should we manage our patients, and what's the role and the place of each of these strategies? So how should we manage atherothrombosis in patients with hemophilia? This is the next question that Robert will soon address. But this brings me to a question. Once one of these four statements is correct, patients with hemophilia are protected against thrombotic events. Patients with hemophilia have a high risk when compared to general population for arterial thrombosis. Patients with hemophilia can develop atherosclerotic disease. And the last one is patients with hemophilia never get an acute myocardial infarction. So which is the right answer? Well, as you suspect, the right one is number 3. Hemophilia, as I just explained you, does not protect against atherosclerosis because the risk factor for atherosclerosis are similar compared to the non-hemophilic population. So let's now move to the next section. Robert, I give you the floor again.